Well, hello, everyone. Welcome to this installment of the Pituitary Brain Tumor Virtual Family Conference. My name is Shana McCormack. I really appreciate the opportunity to be part of this session and to moderate what I know will be a really interesting panel. I want to begin by thanking the organizers, first and foremost, the Raymond Wood Foundation. Also, I'm from Children's Hospital of Philadelphia, and together we are hosting this conference in a new format this year for reasons that are obvious to this group. I'm going to begin with a very, very brief introduction to this particular session, which is entitled Hypothalamic Obesity Clinical Trials Panel. We have some wonderful speakers for you. I appreciate their joining us, and even more importantly, I appreciate all of you coming from many different time zones, taking the time to join us for the session. Very briefly, I'm going to introduce what a clinical trial is for those who may not be familiar. So clinical trials are research studies performed in people, in humans, to evaluate new treatments. And clinical trials are the main way that new treatments, for example, drugs or medical devices, are developed and tested for use for clinicians like myself. Often a clinical trial is used to learn if a new treatment is more effective or has fewer side effects than our currently available options. And in clinical trials, to give you a bit of background for today's talks, it's very common to randomly assign participants to receive either an active treatment, the investigational medicine, or a placebo or an inactive pill to determine the safety and the effectiveness of the new treatment. And when studies have these designs, they're called randomized placebo-controlled trials. The main phases of clinical trials, you may have heard of particular phases, are numbered from 1 through 4. So phase 1 studies test in a small number of healthy volunteers, a new drug. Mainly the goal of those studies are to find a safe dose to bring into testing in patients. And that starts in phase 2. And phase 2 studies obtain preliminary data on whether or not a drug is working and is safe in individuals with the medical condition of interest. Phase 3 trials tend to be larger. They follow up on phase 2. They collect more information about the safety and the effectiveness of drugs in larger populations and may also test different doses. After phase 3 typically is when a drug would be approved by the FDA. And then phase 4 studies continue to monitor the safety and efficacy of those drugs in a larger and more diverse population that might be appropriate for clinical use. So people have many different reasons for participating in clinical trials. First and foremost, clinical trials are the best way to ensure that a new treatment is developed and implemented for as many people with a given condition as possible. By participating in clinical trials, it may be possible for individuals to find out about or access new treatments before they become more widely available. And many people make the choice to participate in a clinical trial because they find that none of the treatments that they've tried thus far to manage their disease have been adequately effective or because they cause too many side effects. One thing that's very important to note for folks is that all clinical trials in the US are required to be listed on a website called www.clinicaltrials.gov. So that's a great resource to look for clinical trials for which you may be eligible. And there are analogous websites for other parts of the world. Individuals who will be presenting today. These are incredible speakers. We're really lucky to hear from them. In the interest of time, I'm not going to do detailed introductions, but I'll just share who they'll be. So we have Ulla Feldt-Rasmussen from Copenhagen, who's going to be telling us about a clinical trial of Tesomet in hypothalamic obesity. We have Dvorak from ConSynance, who's going to be introducing a novel triple monoamine reuptake inhibitor, again, in hypothalamic obesity. And finally, Blandine Cherifi Gatta from University of Bordeaux, who's going to be speaking about GLP-1 receptor analogs. With respect to some housekeeping considerations, All of the questions for all of the speakers are going to be answered in a session, a question and answer session that's going to come at the very end. So you'll notice on your Zoom screen, many folks will be very, very familiar with Zoom by this time. There's a Q&A button, often in the bottom kind of right. So if as the session is proceeding, you have a question, please of course put that into the Q&A box and consider upvoting questions that you think are particularly interesting. And then at the conclusion of the session, we'll go ahead and answer those. Please stay tuned for some opportunities to participate in audience polling. This is a really exciting new feature of our online meeting, so we can get some opinions from the audience as we transition between speakers. And finally, we really are excited to hear your feedback about the session. So at the very end, and we'll remind you about this, there's going to be a link distributed to a survey so we can gather your feedback. So with no further ado, I'm gonna, I believe, introduce the first poll. So I'm going to read the questions for folks who may not be able to see them. We're curious to know which is true specifically for the brain tumor survivor treatment of hypothalamic obesity. So for the particular individual for whom you're responding, have they never tried a medication for weight loss? Have they tried, that's the first option, have they tried the medication for weight loss and found none of them to be at all helpful? Has the individual tried medicines for weight loss and found at least one or perhaps a combination to be somewhat helpful? And final option, has this person tried medications for weight loss and found at least one or a combination to be very helpful? So we're interested in medicine use in this condition and whether or not folks have tried medicines and what their experience was with respect to how well they worked. And I think for those who are able to submit their votes, and we'll see what we find. So I see these coming up. So actually, this is somewhat surprising to me given this audience, but over half of the respondents, so 54%, have actually never tried a medicine for weight loss. And then disappointingly, but also not surprisingly, none have found the medicine to be very helpful. So we're hoping in the future that will change. And there are folks who felt like perhaps there was some benefit or maybe a moderate benefit. So perhaps some of our speakers today will give us more ideas to change the balance of those responses.
Over to you, Ulla. Yes, okay. Share screen, where are we here? Sorry, here. Share. Yes, hello. My name is Ulla Feldt-Rasmussen, as you've been told. I'm from Copenhagen, Denmark, and I'm at the largest university hospital in Denmark, situated in Copenhagen, and being in a tertiary referral center for medical endocrinology and metabolism, which means that I have been responsible for patients like you guys participating with hypothalamic obesity. And I've been dealing with that for more than 30 years, actually. Unfortunately, I can't see you all. That would have been really nice to look you all in the eyes when presenting this. But, well, for obvious reasons, that's not possible these days. So I will just wait a minute. Can I don't know how I can try again, maybe, because it doesn't want to shift to the next slide. I don't know why it doesn't do that, because it did when we tested it. Just click back on the talk. All right. Well, can somebody help me with the technical issue? It worked when we started, when we tested it. I don't know exactly why it's not working. Pause share.
Ulla,
No. Yeah.
I'll have Shana has some tips around.
Well, I was just going to suggest, I see that on the bottom left of your slides, you have forward arrow and back arrow that you might be able to mouse over and click on. Perhaps that will work.
Well, I don't know, maybe. I just can't see that, you see. That's a problem. I can't see anything to put a mouse over. Let me see, resume share. Because I can't see that.
I found clicking on the talk and then it would let me advance, or right click on the talk and use the
there
right.
it came. Oh, it came there.
Yay.
All right, okay. So is it all right now? Sorry for this delay. This is just to show you where the hypothalamus is situated, just in the low end of the brain. It controls the pituitary gland as well as a lot of other functions, and I'll come back to that. But what you see on the right-hand side of the slide, you will see all the hormones that are secreted from the pituitary and controlled by the hypothalamus. So it actually controls all functions in the body. It's connected, the pituitary is connected to the hypothalamus through a stalk. The point here is that if the hypothalamus is damaged, all these essential and many of them life-saving pituitary hormones can be compromised, and the patient will need replacement of usually one or more. But it doesn't only control the pituitary, the hypothalamus also controls a lot of other ways the body functions. One of them is maintaining normal weight, a normal weight balance. So this is just shown in animals. If you injury a particular part of hypothalamus, the animal becomes severely obese, and you have on the other side a normal weight mouse that has not been injured in the hypothalamus. So these injuries, this is what we then call acquired hypothalamic obesity, because it's not genetic, it's not inherited. These are shown on the right side, the functional causes, and some of you may know these syndromes, for instance, Prader-Willi. But what we're dealing with here is the physical causes that are acquired, that are due to very often processes in the area near the hypothalamus, for instance, a craniopharyngioma, which is a tumor. A lot of other different tumors. It can be inflammatory as part of more dispersed diseases in the body. It can be due to performance of neurosurgery, and it can be due to cranioradiotherapy, where the irradiation can also destroy the hypothalamic function, and that can give obesity. This is just a demonstration of what can happen here. If you look on the left-hand side, it's a normal weight girl that has this issue of a brain tumor or craniopharyngioma, which will, in this particular person, elicit an abrupt gain of weight, in this case 150 pounds. And on the right-hand side, you can see where the arrow shows, for instance, a craniopharyngioma, and you have on the left side, normal weight person that through that tumor actually becomes severely obese. So this is a very big challenge, because it's not only weight that is controlled by the hypothalamus, it's also sleep pattern, it's mood disorders, it's libido, it's temperature regulation. So as you can see, it's really a lot of different functions that affect our daily life. And it's unfortunately a condition that is very, very difficult to treat, and has shown to be very difficult to treat. The patients usually continue weight gain, and even diet and exercise doesn't really help. It's either they are unresponsive or resistant to these management measurements due to a increased appetite, very increased appetite. So they are a really big challenge for clinicians, as I am dealing with these patients. We did a study published in 2004 of sibutramine, which is a substance that is centrally acting, and we found in patients with hypothalamic obesity, that was sort of an exploratory trial, so it wasn't randomized and not placebo controlled, that it actually functioned in patients with hypothalamic injury because they lost quite a lot of weight, but it was never approved because of too many side effects to the drug. So now we fortunately had the opportunity to participate again with a substance that is somewhat similar in action, but where it by combining it with another drug, which I will tell you about in a moment, the side effects that were increased heart rhythm and other heart problems, these side effects were alleviated. So after having waited for so many years, we were very, very excited to start this study. And this is how it works. The drug is called Tesomet, and that is a combination of this triple monoamine reuptake inhibitor that was also the case in the previous drug. And it actually reduces both the craving for food, the appetite, and increases the metabolism for fat burn. So the combination with the beta blocker metoprolol can actually make it function without side effects. So what I'm presenting here is just a few top-line results from the phase 2 trial, and you've heard that from Shana, that's sort of exploratory to see if it functions at all on the one hand, and on the other hand, if it's safe. So what I'm demonstrating to you is a first 6 months double-blind trial with placebo and Tesomet, and it turns out that there was really a decreased body weight from baseline, a decrease in waist circumference. The glycemic control and lipid profile were very good, and there was no change in the heart rate, which means it was safe. There were a few of our patients who had side effects. They were not serious, except for one, a patient with anxiety, but the others were sleep problems and dry mouth. And here you can see actually the quite good results of a 6.3% extra weight loss in the active arm compared to the placebo. And you can see quite a substantial number of patients had an impressive weight loss, as you see on the right-hand side. The waist circumference, which is usually quite important for demonstrating a positive type of weight loss with the loss of weight, loss of fat, was also very impressive. So it's actually the summary we can get out of this is that there were clinically meaningful improvements over these 24 weeks with the reduction in body weight, reduction in waist circumference, no meaningful side effects that was really damaging to the patients. And we have a further 6 months open label extension study that we are waiting to lock the database and look at the results. So we really hope that this drug will be put further into phase 3 trials, which are necessary for the approval by the FDA and other health authorities. And you have a link here for what that might be. And I will end by this, just telling you that I'm being bombarded now by our patients who are off the drug, that they really, really hope, and I promise to tell you that, to share with you, that they are really waiting to get back on the medication again, eventually in a new trial. Thank you very much.
All right, Ulla, thank you so much. And a reminder to folks, I see some questions coming through in the Q&A already, which is really wonderful. If you have questions for Ulla while they're fresh in your mind, please, of course, put those in the Q&A, and we'll address them during that session. So now I think we have another poll to help us before we transition to our next speaker. This one's shorter for me to read, and I think I have an intuition on the answer, but let's see what the group thinks. So the question is, how much of a problem is hypothalamic obesity for the brain tumor survivor for whom you're responding with respect to overall quality of life? So if you had to give kind of a big picture assessment, the choices here are mild impact, moderate impact, a severe impact, or final choice would be no impact at all. So I'm going to give you a moment to respond, and then I'll see what the group says. And our organizer may be keeping us in suspense. Oh, there it is. So unfortunately, this is not surprising to me. We've had no one select no impact or mild impact, and the sizable majority of folks joining us report severe impact on quality of life. So I'm hopeful that some of the options that we present here can address that for sure. So we'll transition to our next speaker now.
Okay, so hello everybody. I first want to thank the organizer for giving me the opportunity to present today about GLP-1 analogs as a potential treatment option for hypothalamic obesity. I'm coming from Bordeaux, where I'm a physician taking care of obese patients, and especially patients suffering from hypothalamic obesity. So first, a quick presentation of GLP-1 and GLP-1 analog. So GLP-1 is a gut-derived peptide synthesized by intestinal L cell in response to ingestion of glucose and ingestion of a mixed meal. It increases glucose-dependent insulin secretion and is used as a treatment. GLP-1 analogs as used as treatment in type 2 diabetes, but GLP-1 has also other action and especially decrease appetite. GLP-1 analogs, both short-acting and long-acting, have been synthesized and have the same actions more or less than GLP-1, and as I previously told, are used in the treatment of type 2 diabetes. The role of GLP-1 on food intake is known for long times, and here you can see that infusion of GLP-1 in humans can increase satiety, gastric fullness, and decrease hunger and food intake and energy intake during a buffet compared to saline. Indeed, it's now well known that GLP-1 analog is an efficient treatment in common obesity. And here you can see that liraglutide, a long-acting GLP-1 analog, can significantly reduce body weight in obese patients compared to placebo. And this effect is maintained all along the treatment. However, in the context of hypothalamic obesity, it is very important to know where does GLP-1 act. And this study gives some interesting answers. Indeed, the authors measured the postprandial concentration of endogenous GLP-1 and the activation of brain regions after meal intake. And they show that there was a positive correlation between postprandial endogenous GLP-1 concentration, and activation of some brain regions, here the hypothalamus, but also here the prefrontal cortex that is involved in food intake, meaning that GLP-1 is acting on other brain regions than hypothalamus. Another evidence comes from this study. On the left panel, you can see that obese patients do have higher activation of insula and amygdala, brain regions involved in reward, after seeing picture of food. And this activation is higher in obese people compared to lean. In the right panel of the slide, you can see that treatment by exenatide, a GLP-1 analog, can reduce activation of these regions involved in brain reward, meaning again that GLP-1 is acting through other brain regions than hypothalamus. In addition, there is also data showing that GLP-1 analogs can decrease body weight through peripheral mechanism. And here, in these women treated by exenatide, those who were responder, who decreased their body weight, also had an increase of energy expenditure, meaning that peripheral mechanism can be involved in body weight loss induced by GLP-1 analogs. Other mechanisms can be also involved, especially cognitive effects, and it has been shown that GLP-1 analogs has receptor on hippocampus, but we will not detail these data. Well, so GLP-1 analogs has been then thought as a potential treatment of hypothalamic obesity. And here I show you the first case of the patient who was initially treated by GLP-1 analogs, initially short-acting exenatide, and then long-acting liraglutide. And you can see that after the beginning of this GLP-1 analogs treatment, body weight significantly decreased and didn't increase after. After that first case came 9 cases published in 2013, 8 patients were maintained on exenatide and 1 on liraglutide. 1 patient had to stop the treatment because of gastrointestinal disorders. But for the 8 others, the treatment was maintained and was quite efficient, since body weight decreased from 120 to 107 and BMI from 27 to 23. Now came the first randomized clinical trial that was very recently published by Ross and colleagues. Bidurion 2 milligrams per week was administered to patients suffering from hypothalamic obesity, aged between 10 and 25. This was a double-blind placebo-controlled randomized study. The study was designed as follows. It was a total duration of 56 weeks, 2 weeks run-in, 36 weeks treatment, and 18 weeks open label treatment. The primary outcome was the 36 weeks percentage change in BMI. And you can see here the secondary outcomes: change in BMI, waist circumference, waist-hip ratio, fat and lean mass, and blood variables. Here you can see the change of percentage of BMI in patients treated with GLP-1 analogs, with some decreasing the percentage of BMI and some increasing. And here in the panel B, you have the change in percentage of BMI for patients who were maintained on placebo. The results on body fat are really interesting, as you can see that some patients maintained on treatment decrease the percentage of body fat, while patients maintained of placebo do all increase the percentage of body fat. This is summarized on that table, and you can see that the change on waist circumference and total adipose tissue was significantly different between treatment and placebo. In addition, there were patients that lost more than 5% of BMI in the treatment group, but no patient on the group of placebo. Another randomized clinical trial will come soon, and I was the PI of a study conducted in adults that was evaluating the efficacy and safety of exenatide in adult patients suffering from hypothalamic obesity. So, to conclude, GLP-1 analogs are a potential treatment option for hypothalamic obesity because actions are independent of intact hypothalamic pathway. In addition, a very recent published RCT demonstrated the effects of GLP-1 receptor analogs to reduce or stabilize BMI and body fat. However, hypothalamic obesity is a complex multifactorial disease, and we have seen the heterogeneity of responses. So we still need to characterize these patients in terms of eating behavior, sleep, energy expenditure, cognition, and we still more clinical research to better treat these patients. I thank you for your attention.
All right. Thank you so much for that terrific talk. As a reminder to include your questions in the Q&A for Blandine, and we'll regroup with her during the question and answer session. And before we have our last speaker, I'd invite our last poll to show. This is an interesting question to me. I'm curious what folks will respond here. The question is, does the brain tumor survivor have an abnormally strong sensation of hunger and desire to eat? This also gets called hyperphagia. And so we're asked for the brain tumor survivor, is this abnormally increased sensation of hunger present to a mild extent, to a moderate extent, to a severe extent, or not at all? And we'll wait for your responses. So it's interesting, we have a bit more of a distribution. So the one person who said not at all, some folks who mentioned severe, and then there's mild and moderate. And this resonates with my clinical experience too. Thanks very much for these answers. So we'll next switch gears over to our final speaker.
Good afternoon, everyone. My name is Dvorak. I'm the Chief Medical Officer of ConSynance Therapeutics, and it is a pleasure and privilege to be here today. We very much like to thank the organizers for an opportunity to present our data. So I'm here today to share the results of phase 1 studies done with a novel triple monoamine reuptake inhibitor for the treatment of rare obesity disorders. The name and number of the drug at this point is CSTI 500. And it is a novel triple monoamine reuptake inhibitor of serotonin, dopamine, and norepinephrine. It is actually pharmacologically quite similar to Tesomet from Saniona, and you heard about that drug from Dr. Rasmussen in her talk earlier. It is, however, a more potent reuptake inhibitor of serotonin at SSRI level versus Tesomet. Also, the drug does not require a metoprolol, and we plan to use precision dosing to individual patients as a way to administer the drug. We have completed phase 1 studies with the drug, both single and multiple dose. The drug was well tolerated with no unexpected side effects. The PK was very close to dose proportional, only with moderate variability. And the cardiovascular effects were similar to other drugs in this class. We have also completed human PET study to confirm target engagement at predicted efficacy levels of the drug. And the drug is currently in development for hypothalamic injury-induced obesity and Prader-Willi syndrome. And you also heard from Dr. Rasmussen about the severity of damage, and you know about it very well, to hypothalamus. And so it will come as no surprise to you that is really very important because of what's happening to these patients and how severe their problems are, that you really need to attack it from multiple angles. And that's where these triple reuptake inhibitors come from. And that's why we are so excited about their potential, because you really need to affect all of these neurotransmitters to deliver the clinically meaningful efficacy you all have been looking for. So that's where the reuptake inhibition of norepinephrine, which would affect satiety and energy expenditure, serotonin, which has an effect on compulsive eating, satiety and appetite, and dopamine, which would improve craving for food, have an effect on appetite and reward, all need to come together to have this effect. And the only 2 drugs to date which have been able to show this type of profile is actually tesofensine, which is part of Tesomet from Saniona, and our drug, CSTI 500. So this is a very brief overview of our single-dose study where we dosed 51 subjects at doses of 250 milligrams, and the drug was safe and well tolerated up to 100 milligrams. The adverse event profile was consistent with the pharmacology of these triple reuptake inhibitors, and the dose-limiting side effects at 150 milligram dose, which was non-tolerated, were nausea and vomiting. And it is important to note that there were no evidence for psychostimulating effects or abuse potential for the drug. We also completed the multiple ascending dose for the trial, where a total of 36 subjects, 6 females, received CSTI 500. Males were given and tolerated doses 3, 10, 30, 45, and 60 milligrams a day for 14 days. And we tested females at 45 milligrams for 14 days. The most frequently reported adverse events were actually headache and nausea. The cardiovascular effects, which are very important safety concern in this class of drugs, were quite modest. There was actually no difference in blood pressure noted in subjects treated with CSTI 500 compared to placebo. The treatment with the drug was associated with small increase in heart rate upon standing when compared to placebo. And overall, the profile was quite similar to tesofensine and other drugs of this class. There were no marked abnormalities in clinical labs or ECGs. And very importantly, even though this was not a weight loss trial, we did note an effect on body weight, where in males at doses from 30 to 60 milligrams, there was about 2.5% mean weight loss over 2 weeks. And in that female cohort at 45 milligrams, it was about 4.5% mean weight loss. Again, there were few activating adverse events at higher doses, such as sleep disturbance and restlessness. And based on available data, the potential for abuse liability for this compound seems to be very low. As I already mentioned, we also completed a PET imaging study for the trial to confirm whether the drug binds and activates the centers in the brain which we want to affect. And as you can see here on the left panel for serotonin, we saw quite a bit of good activity, which is the red color. So redder the color is, more activity there is in that region. So on left, you can see very good engagement for serotonin in the right region of the brain, and on the right panel, you see the same for dopamine. And based on this data, we are able to confirm a very unique feature of this drug, where given its high effect on serotonin reuptake inhibition, essentially on a backbone of a serotonin reuptake inhibition at a level of SSRIs, we can dial in the effects on dopamine and norepinephrine. As we go up in the dose of the drug, you'll have more, and you'll have already good activity on serotonin and more increasing activity on both dopamine and norepinephrine. And based on this principle also will be based our unique individualized dosing for each patient. So in addition actually to reduction in body weight and appetite and satiety, which one would expect from a drug in this class, due to its pharmacological profile, we could also expect in some patients, depending on what's happening with them and their issues, some other effects. For example, increased positive mood and improvement in apathy, increase in other things than just food, slower eating, improved concentration and focus, better decision-making, and improve overall performance, perhaps both in school and exercise. And currently, we are planning to initiate phase 2 of this drug, about which we are very excited in the first half of next year. Thank you very much for